And now we'll learn more about that kind of patient. Dr. Reshma will now speak about pitfalls in premium IOLs and handling the unhappy patient. Dr. Reshma is a prolific cataract surgeon from Mumbai, and we look forward to hearing what she has to say.
Hello everyone, and I don't know, best for the last, should I say that? But everybody has been talking so much about these premium IELTS. I think this will be pretty much a recap of the all the discussions that I've had earlier. So, so why premium IELTS now? It's more like a necessity. I think we all sit in our clinic and we have patients who have higher expectations. It's become a refractive procedure, and so what all we need to keep in mind is that now with the entire evolution of the biometry, amazing new formulas have come in, and the IOLs are also available that correct presbyopia. Hence, even the expectation from the patient and as well as from us to deliver to the patient has become very high. So as Albert Einstein said that if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. So what it means more is that when we have a patient who's sitting and who's for a premium aisle, we need to do our homework extremely well. We have to first think in our mind, what is this patient's expectations? Patient selection is extremely important because just an over expecting patient who comes with say a patient sits and even he's bothered about the little bit of cataract that, and he just talks a lot more about that small cataract that he has. That these kind of patients are extremely picky, so we have to select the patient discreetly. Pre-op counseling, as Dr. Parul and a lot of our other speakers have already mentioned, of course counseling is very, very important. Surgical planning, peri-op management, and management of expectations, I think that's very, very, very important. So what do we do as a homework for ourselves? Refraction test both the eyes. There are times when we've heard just that when the patient comes in and the right eye surgery, then you just do about the right eye. No, do just test both the eyes properly. Test vision at all distances and develop a rapport with your patient. Help to know the patient's range of requirement, because every patient has a different range for reading and intermediate. So when I do a refraction of a patient and I see that, okay, where are you really holding your newspaper? Have you ever asked that to your patient? Where are you comfortable? Because a lot of patients who we feel are holding at 33 centimeters, but they say, no, I'm not comfortable here. I always put at 40 centimeters. So that's where we have to understand the range of where the patient really wants it and make it customized accordingly. On table, in the OPD, we have to see the slit lamp, see for the tear film, assess the tear film and ocular surface, the T-bar time, the Schomers. If the tear film is suboptimal, there may be an issue related to the tear volume or tear quality. Meibomian gland analysis, very important. Rapid T-bar can be due to MGD. A thick MG secretion can result in suboptimal vision and unhappy patient. So even after doing a fantastic surgery, even after putting the lens properly, yet the patient is unhappy, this is something we have to go back and think that is this the issue that the patient is facing. The endothelium, we have to look at the guttatas, see if that is the cause of the poor vision. The pupil size, centration, angle kappa, we all know about it. Pupil size is most important because if there's an unhappy multifocal lens patient, a photopic pupil size should be close to 3 millimeter, whereas a scotopic ideally should be 5 to 6 millimeters. Before doing the surgery, we have to look at the corneal topography, as Dr. Nitin has already talked about. A tall EKR, a peak, a good K-metry spread, regular overall. Look for the white to white. Make sure there are no Fuchs dystrophy or any other corneal endothelial issues, and astigmatism. Of course, we know it's extremely important, and most cases are related to residual cylinder causing the patient to be unhappy. The macula has to be checked very discreetly. Do an OCT in all patients. Do not miss on any subclinical ERM or aneurysms. Diabetic ARMD cases are best to be avoided. So, what are the main things that we have to look in? Why would a patient be unhappy even after putting the best lens, even after doing a fantastic surgery? So, these are all the red flag things. A very high demanding patient who wears glasses, even for low refractive errors, all the time. You know, these kind of patients are very, very highly demanding, and hence, this is one of the very important selection criteria that you really want to go in for a multifocal lens for that patient, particularly animated in describing every detail of his or her cataract visual disability. The patient obviously with a severe dry eyes, now that has become important criteria to check before going ahead with a multifocal lens. Evaluate for any high order aberrations, angle kappa, astigmatism, inaccurate biometry. Barrett universal has to be used for all patients that we go in for a multifocal. Refine your nomograms for cylindrical correction and markings. So, a patient who's already got a surgery done and he comes and he's really unhappy even after that, there could be a negative, there could be a negative or positive or a dysphotopsia. And in such cases, we have to look in carefully, and if required, a YAG laser should be done for this patient to release that. Or also, if there is, you have to check if there is any IL decentration, and if there is a PCO, of course, get a uh, patient would be unhappy even after doing a multifocal. You have to look in for other factors, like you've done everything, but why is the patient still unhappy? So, identify the ideal multifocal lens, rule out all the red flags. Advanced technology for pre-op planning are available. Please use them. Close the loop by tracking results and modifying pre-op process accordingly. Logical stepwise approach helps to frame the problems and take the right step towards solution. And small subset of patients may need exchange, but this too can be avoided by meticulous pre-op homework. Now, this is just quickly showing some of the patients. This patient that we has been done on anterior readings, and we look at what is the final biometric reading that we are planning to put in for the patient. So, if this is showing, say, 11 diopter for the patient to be given for premium IL, and check properly on pentacam as well. Do all proper readings from couple of different machines so that we are finally sure. So even that was also done, the patient was also done IL master, and here in both that we find that the we're getting the same results is when we finally go ahead doing the putting in that kind of lens. So what I'm trying to explain here is that don't just go by the results from one. If you are not sure, go in for multiple different formulas and finally decide which lens we want to insert in. In case of toric calculations, also it's important to get the so there is in the toric calculation, basically when we use lenses, it is we have to see the ACDs, and the ACD depth is very important. And if we look into details about every aspect of it, we eventually get a happy patient. So ACD plays an important role in effective lens position prediction and cylinder power exerted at the corneal plane. As per studies, it is shown that in eyes with deep ACD, a given toric IOL will correct a lower amount of corneal cylinder than in one with the normal eye ACD. And conversely, for a hyperopic eye, the same IOL will correct a higher amount of corneal cylinder. So this is a hyperopic patient. Now, if there are two different formulae, two different toric powers, which one should we choose? So if you can see in the left eye, the ACD was not used as one of the components. It was showing as a 25, and otherwise it is a T3. So it changes if you put the formula with the ACD, it gives us a more accurate result. Posterior corneal astigmatism. So in previous calculations, assume anterior and posterior corneal curvatures have a constant ratio. Many studies have found that posterior corneal curvatures vary wildly among individual patients. Ignoring posterior corneal astigmatism may yield incorrect estimation of total corneal astigmatism. This has already been covered earlier with earlier speakers, but I will quickly give a recap that increasing age and the posterior corneal astigmatism has a correlation. So affects astigmatism of the anterior more than posterior corneal astigmatism. By increasing age, the step meridian of the anterior corneal surface tends to change in direction from vertical to horizontal. The posterior corneal astigmatism will compensate the anterior corneal astigmatism in younger population and increase the total corneal astigmatism in older population. The anterior corneal surface, which is in contact with air, has a positive refractive power, whereas the posterior corneal surface in contact with the aqueous has a negative. Hence, a vertically aligned steep meridian on the posterior corneal surface generates an against the rule rather than with the rule astigmatism. The average power of posterior corneal astigmatism is about half diopter, and this value should be added to the anterior um, against the rule astigmatism and subtracted from the anterior WTR astigmatism to determine the total corneal astigmatism. If the meridians of the anterior and posterior corneal astigmatism are same, posterior corneal astigmatism reduces the anterior corneal astigmatism, whereas if they are 90 degrees apart, then it increases. So this is just a quick surgery that just 1 more minute remaining, ma'am. So here to show that it is very important in toric lenses, Dr. Ballad had put up this point that when the lens is introduced inside, very important for toric lenses is when we are aligning the lens, it has to be first put about 10 to 15 diopters away, and then a very thorough wash removing all the viscoelastics, not only from above the lens but also from below the lens. It's important to tap the lens so all the from all the viscoelastic is removed, and a clear and everything should be cleared and then aligned it to the exact position. So in conclusion, the pre-op exam and counseling and calculation is a very important surgical process. As I said, what all we need to do to prevent any mishaps, and post-op looking at the results. Thank you so much.
Thank you, Dr. Reshma, for beautifully summarizing how to avoid the unhappy patient.
Correct.
Yeah, I'll just like to say a point that your surgery has to be really perfect with multifocals, and one important point is your centration. Now, if you're doing your patient under topical, it's very easy. You ask the patient to look into the microscope light, and your Purkinje 1 and 4 images should come close to each other. Because if your IOL is not well centered, then it's really going to lead to a lot of dysphotopsias post-operatively. Secondly, if you have any kind of a complication, a zonular dialysis, put in a CTR, don't leave it just like that and put in a multifocal lens. Or if you have a PC rent, then you need to really reassess. Do you want to put a multifocal? If you think you can get a stable multifocal by, say, doing an optic capture, you can do it, but you also know that even that slight difference in positioning of your multifocal IOL can lead to a post-op result. So such patients can be counseled that they may need to have a top-up like a PRK or a LASIK post-operatively. And whether you want to do it complementary or the patient pays for it is a different matter, but you can counsel the patients immediately so that they're not disappointed and unhappy with the results.
Thank you.
Thank you. Yes, Nitin. Can we have the microscope, the microphone?
I think it's very important in all cases of multifocal IOLs also to check the angle alpha and the angle kappa, because angle alpha more than 0.5 in preoperative biometries, I think this patient is going to be a bad patient for a multifocal IOL. So it's better to avoid those patients than to burn your fingers.
Yeah, but later. Unfortunately, Nitin, how many of us have access to the iTrace? Because angle alpha is not available.
You can get it on the IOL mask on optical.
No, you get angle kappa and that. You don't get angle alpha.
But then you can extrapolate it, and there are ways of actually calculating. It's
Really?
a mathematical formula.
Okay.
You can extrapolate it from your angle kappa.
Right. Yeah.
CME is increase. Earlier we were talking CME, third macular edema.
No. No, not at all. Not at all. It's only, I mean, it depends on how clean a surgery you're doing, or if your patient is diabetic, then the chances of post-op CME, or if you have any complication, PC rent or something. But of course, these patients are premium patients, so you're definitely going to put them on some NSAIDs a couple of days before. So
Also
you need to optimize everything.
Also a pre-op OCT in cases of all patients with multifocal IOL, because you may have a juxtafoveal telangiectasia or something, and this patient which you may have missed on normal fundus examination, or a thin ERM, which can
How many of us have a pre-op package for our multifocal patients? So include your optical biometry, your pentacam, your OCT, all
dry
part
workup.
of it.
Yeah, should be done.
Actually, for all patients, they go through the same thing because you cannot predict.
Meenakshi, you're working in an institutional setup with everything available, but we have to charge our patients for all of that.
We also have to charge our patients as much. It works the same way whether you are in an institution or in a...
Ideally, yes.
Yeah.
Yes.
Ritu has one more talk. Yeah, so there's Ritu is just giving us an A-logarithmic approach to premium IOLs. And any other questions while she's, yes?
Just a basic question. While doing the immersion scan, the company people had told that even the LED light affects the axial lens sometimes. Does it really happen or not that?
No. I don't do it myself, but I don't think it's made such a difference to our outcomes. Yeah.
Other than asking the patient to just look straight ahead, we need to give them a light target or nothing.
If some of the patients are moving and are not so cooperative, yes, you give them a target. But usually if you tell them to look up, and mostly patients can manage, of course, you give Paracane and explain what you're doing. I don't think uncooperative patients are always there, and so then
With the lights on or off or nothing.
I don't think so, no.
Dr. Arvind, this is a very hypothetical question, but has it ever happened that any of the retina surgeons had to operate on a patient with multifocal IOL, and does it make their surgery difficult?
Apparently, it doesn't make their surgery difficult. I don't think any retinal surgeons left here now, but apparently it doesn't make. But if you know that the patient may develop some kind of retinal pathology like a diabetic, or you might want to avoid putting a multifocal if you think that they're going forward that they may. Having said that, I have many diabetics also who have no retinopathy, and we've put multifocal and they're quite happy.